first speaker today is Dr. Molly Fleece. She is an assistant professor in the UAB Division of Infectious Diseases, an associate healthcare epidemiologist for the UAB Health System. Dr. Fleece completed her medical degree at the University of South Alabama College of Medicine. She then completed her internal medicine residency and infectious disease fellowship training at the University of West Virginia. She is a clinician educator with interest in general infectious disease, antibiotic resistance, hospital-acquired infections, and prevention. So thank you very much, Dr. Fleece, for being here. And she is here to talk about the cold and flu season.
So thank you so much for the introduction. I'm happy to talk with you guys this morning. And so this will have some COVID themes to it, but it is really nice to talk about something not completely COVID related after this past year and a half, 2 years. So the hope of this talk is to touch on influenza viruses, as well as other respiratory viruses that circulate during the school year, talk a little bit about cases, transmission, and complications, specifically in children, compare the symptoms of the cold, flu, and COVID in kids, touch briefly on testing and treatment options, and then some recommendations on how to reduce the spread of influenza in schools. So this is our influenza virus. It is a single-stranded RNA virus that we have come to know very well from each annual flu season. There are three subtypes of flu viruses that tend to infect humans, with influenza A and influenza B being the two most prominent. Influenza A subtypes are varied, and they're mainly determined by these, let me minimize this box here, neuraminidase little surface molecules and hemagglutinin and surface proteins as well. There are numerous different types of HAs and NA antigens, and those various subtypes are what determines, or those various combinations are what determines that particular subtype of influenza A. And that becomes important as we think about the different circulating strains and the different strains that get tossed around in the media, particularly about epidemics and pandemics of the past, which I'll mention briefly in a moment. Influenza B, we typically think about as not as common and maybe not as severe of a subtype, although in children and people with underlying decreased immune systems can certainly cause a severe illness. Unlike influenza A subtypes, where there are a lot of different subtypes with those HA and NA combinations, there are only two subtypes of B, so the Yamaguchi subtype and Victoria subtype. And then influenza C is really not very relevant to causing human disease. It's rather uncommon, so just to acknowledge that it's there, but we won't spend any time talking about it. And the key with flu, and the reason why annual flu vaccines are so important, and the reason why to date we do not just have one universal flu vaccine, is this concept of antigenic change. And so often we have some recombinations or some slight changes to those neuraminidase and hemagglutinin antigens. And with those slight changes, it changes enough of the virus each year to cause a new influenza epidemic, meaning rampant circulation in the community, but that's a localized community, so within the US, for example, or within certain countries. And with those single changes or slight drifts in these antigens, that is what prompts or causes these epidemics. Whereas with pandemics, you have a bigger change, a bigger recombination of genetic material markers with the flu, either with different flu strains that recombine together, or between human strains and animal strains. And when you have such a big change in that mechanism, that is what is responsible for influenza pandemics. So epidemics that then can cross country borders, becoming more of a worldwide concern like we have currently with COVID. And so there have been many different influenza pandemics throughout the history of the world and recorded history, with the first one, excuse me, the first pandemic really attributable to the flu documented in the 1500s, as best we can tell from the literature. The two most common pandemics that we think about and hear about with relation to the flu are the 1918 avian flu or Spanish flu, and then the 2009 influenza A, H1N1, or the swine flu. So thinking about 1918's pandemic, and this was called the Spanish flu mainly as a misnomer. It was originally thought to come from Spain, which was not true. It actually originated from the US-Mexico border area, probably with some recombination of bird and other animal viral markers, and really was a big deal during World War II. And so because of all of the conditions around the World War with close quarters, people moving across borders, the lack of vaccinations set this up to be quite the experience for several years, with significant number of deaths, significant morbidity, and you can see in this picture, you know, a military base, probably with, you know, hundreds of people who have died, unfortunately, in this clinic. This was an influenza A pandemic, also H1N1, and you'll see that that was the same as in 2009. But those strains are very different. The 2009 strain did originate from probably human and swine strains. It had a lot of fear associated with it, tended to impact younger populations because the younger populations had not seen a virus that was similar enough to this H1N1 strain, whereas older populations had had exposure in the past to something that was somewhat similar. You know, this was one that we lived through during our lifetime. So just two different flu pandemics that certainly have made the media in the past, and that we have turned to when thinking about COVID. So each week, the CDC publishes weekly influenza surveillance reports. And so I just wanted to show sort of where we were through the week of October 9th. Probably today is when they'll release the data from the week after this. I just haven't seen it yet. But so far, we have not across the country seen much in terms of flu. So you can see up until this week of October 9th, under 50 cases. About 43, more A than B, but certainly the percent positive rate is very low at about 0.1, 0.2%. Because all of these cases have been submitted for at least typing as either A or B, not necessarily serotyping. The graph on the right, you can see sort of subtypes out with A, not subtyped A, H1N1, H3N2, where there have been a handful, and then a split of the Yamagata and Victoria lineages of influenza B. So in general, across the country, we have not seen much flu activity yet, which is great. Alabama, or the ADPH, does publish something similar as well, just with our internal data. And this is looking at the percentage of outpatient visits for influenza-like illness by week and season. So across this bottom, let's see, we'll do the lighter blue first. This is 2019, 2020. So mostly pre-COVID, although I guess partially this is during COVID times. The darker blue is the 2021 season. And then here we are in the red with the beginning of 2021, 2022. So right now we are at a statewide influenza-like illness percentage of about 1.6%, which is below average or below baseline, which you can see here in the light gray line. In the state, we have not had any flu cases in the last 3 weeks, which is great. But this is capturing influenza-like illnesses. And as we all know that we have COVID circulating fairly rampantly around the state, as well as other respiratory viruses that honestly we did not see a lot of last year because of masking. So we have rhinovirus, enterovirus, respiratory syncytial virus, and adenoviruses that are circulating fairly frequently. So as you can tell, it's not subtle. There's a big difference between what we normally see every flu season with this light blue line, what we saw last year, which is hardly any flu, and where we are right now. And the biggest difference between light blue line and dark blue line was masking, social distancing, and the disruption of our lives from the past year because of COVID. So thinking about children in general, influenza is quite dangerous for kids. So each year, millions of children get sick with seasonal flu. Looking at average hospitalizations from various different flu seasons going back in the last 10 years, it depends based on the seasonal circulating viral strain and how well that viral strain matches our vaccines and how many of our kids are vaccinated. But hospitalizations among children less than 5 are not insignificant in the range anywhere from 7 to 26, 30,000 per year. And each year, unfortunately, we do have a handful of pediatric deaths around the country. You'll see numbers sort of across the board, but on average, anywhere from the 30s to maybe 200 kiddos die every year. And there's an asterisk there for a couple of reasons. One, in 2009, with that H1N1 pandemic, there were significantly more pediatric flu-related deaths than in years prior, almost 400, most of whom were not vaccinated. And in the 2019-2020 season, again, the CDC, through different models, thinks that that number was underrepresented, that 199 model, with other models suggesting maybe 434 deaths or so. So looking at numbers by region, you can see that we are down here in the dark blue, which is not where we want to be, with over 2.5 pediatric deaths per 1 million population. And so, and I think that has to do with maybe vaccination rates and other things. And then this breaks it out by season. And you can see that in 2019, 2020, with our number of 199 and probably up into the 300s that was underrepresented, that was a new tragic milestone with more deaths in kids than we had seen historically in the past. And, again, last season was very different through all the different measures that we did with COVID, but particularly with masking, since COVID vaccines were not applicable to children and may be applicable to children later this year. But the difference between seasons in the past and seasons last year was quite remarkable. So last year across the country, we only had 1 documented pediatric flu death, which is incredible. And I think masks were a significant role of that, as well as distancing. In general, who these kiddos are that die every year from flu, most are less than 5, a handful of are less than 6 months, and about half have some pre-existing medical condition. So thinking about other things other than pediatric deaths, influenza complications in children are fairly common, especially in those kids less than 2, as well as less than 6 months. And that has to do with a variety of things, whether that's a secondary bacterial pneumonia with things like strep pneumo, which is very common, Haemophilus influenza, another bacterial cause of pneumonia, as well as Staph aureus, which is sort of the classic bacterial association with post-flu pneumonia. Dehydration is a big deal in children. And then, as is the worsening of long-term medical problems, whether that be heart disease or asthma, brain dysfunction like encephalopathy or fatigue, as well as other things we think about, sinus problems, ear infections. And then this entity called Reye syndrome, which is a rare but very serious condition in children who receive aspirin inappropriately in the setting of influenza. And they can come in with very severe illness, including brain swelling. Very rarely these complications can lead to death, but they are important to know as they do cause significant morbidity, if not mortality. So how does influenza spread? I feel like this has been a topic of conversation in terms of spreading of illness over the course of COVID. And so similarly to COVID, flu spreads via respiratory droplets. It is a moderate sized respiratory droplet, typically through, like this picture shows, either coughing, sneezing, or loud talking, yelling, singing, those types of things. You still have to be within a certain distance. It's not airborne. And so that's where that 6 feet apart number typically comes from. And then to a lesser degree, probably spread through human transmission, whether through handshaking, physical touching, and then subsequently touching your eyes, nose, or mouth, and then some spread through fomites as well. So common objects, so things you think about in the classroom, computers, doorknobs, commonly used classroom devices, those types of things. In terms of symptoms, flu symptoms start very suddenly. People can tell you when they started feeling sick, and that's different from other respiratory viruses that may start a little bit more subtly, even including COVID. Oftentimes patients will, or people, children, will note cough, sore throat, and a runny and stuffy nose. Fever, chills, and body aches are a big deal, as is headache, this general sense of fatigue. And then more often in children than any other population, these kids will have vomiting and diarrhea. And that vomiting and diarrhea is one thing that sets flu apart from other respiratory viruses, where systemic symptoms, including GI symptoms, are not very common. There are some warning signs of flu. So thinking about those symptoms and what would occur in those different categories that make you think these children are getting sick and need to be seen, certainly by a medical professional, but maybe in the hospital. And oftentimes that has to do with breathing. And so any fast breathing or trouble breathing, bluish discoloration of the lips or the face, that might indicate decreased oxygen levels circulating, or decreased oxygen that is being absorbed by these patients. In younger kids, ribs pulling in or retractions with each breath is important to pay attention to, as is chest pain. Younger children may simply refuse to walk, and that can be an indication, especially in those who are not able to communicate clearly about their symptoms, that they're having just severe muscle pain or muscle breakdown. Dehydration is really important to monitor for, more so than kids, than adults, where we can monitor our water intake and be able to communicate more clearly when we're feeling dehydrated. Children may just not urinate for many hours, may complain of dry mouth, or fairly importantly, just not have tears when they cry. The rest of the list talks about more systemic symptoms like fever over 104, any fever in a child less than 12 weeks, worsening of their chronic medical conditions, and then some neurologic complications if they are not as alert or interactive while they are awake, or certainly if they're having seizures related to either a high fever or any brain swelling associated with dehydration and those types of things. The kids we worry about as being higher risk are basically anyone less than 5 years old, but certainly less than 6 months. There is a signal in American Indians and Alaskan Native children that they are at higher risk of complications. And then those with these chronic underlying medical or health problems. And these make sense. So kids with asthma or other underlying chronic lung disease, they have a lower threshold to tip over into severe illness if they were to get sick. Children with neurologic complications may not be able to communicate as clearly when they are not feeling well, or be able to communicate their symptoms like the severe muscle pain and those types of things. Heart disease, just thinking about fluid shifts, our children with congenital heart disease are at higher risk, as are our patients with sickle cell disease, kidney liver disease, metabolic disease, and inherited diseases like mitochondrial disorders, those types of things. Any child with immunosuppression, so either any underlying medical condition that makes them immunosuppressed, or if they take medications that reduce their immune system. And then childhood obesity is a big category here in the Southeast, unfortunately, would place these children at higher risk as well. And then thinking about aspirin and that Ray syndrome that I mentioned earlier. So how would one distinguish between the common cold and flu? There are a lot of similarities, but then also a lot of differences. So both the flu and cold, are caused by contagious respiratory viruses. They're just caused by different viruses. So influenza virus is responsible for the flu, whereas there are a myriad of viruses that are responsible for the common cold, including that rhinoenterovirus, parainfluenza, which is circulating fairly frequently right now in our state, as is the seasonal or non-COVID coronaviruses, which are extremely common in addition to rhinovirus. Across the board, influenza causes more severe symptoms than the common cold, whereas common cold symptoms are generally more mild. And the onset with the cold is generally more gradual. Kids or adults are generally not able to say, this was the day that I started to feel sick at this time, whereas that's how it is with flu. So looking here, fevers with cold are generally more rare, whereas oftentimes with the flu, kids and adults will complain of fever, myalgias, and fatigue, as well as chills. More often than not, if you're sneezing, it's probably more of one of the regular cold viruses. Cough is more common with the flu versus cold, but can happen. And then you see these stuffy nose, sore throat, more common with cold, headache being more common with the flu. So these types of comparison tables are just helpful when you're trying to discern at home before you go to the doctor or before you get any testing. Could I have the flu or could I have the cold? It's really based on symptom onset and what the symptoms are. Unfortunately, with flu and COVID, there are a lot of similarities, some differences, and that's what makes the concept of having rampant COVID and rampant flu very difficult to think through and manage. So I was going to spend a little bit more time on these similarities and differences because I think with the loosening of some restrictions with distancing and masking that we're seeing throughout our state this winter, we have the potential to see really for the first time a potentially normal influenza season on top of a potential next surge of COVID. And so in terms of signs and symptoms of flu and COVID, you can see here there are a lot of similarities. Fever, cough, chills, shortness of breath, symptoms that have been all over the media about COVID and signs and symptoms that we have come to be familiar with the flu every year. And again, vomiting and diarrhea in children is much more of an issue than in adults. Differences certainly with COVID is the characteristic change in or loss of taste and smell that we really do not see with any of our other respiratory viruses to date. In terms of symptoms after exposure, so you have a child in school who has been exposed to the flu or COVID. When may they expect to develop symptoms? And so similarities between these two, at least 1 or more days can pass between when a person is infected and when they may show symptoms. With the flu, symptoms oftentimes develop 1 to 4 days or so after infection occurs. Whereas with COVID, the range is long, anywhere from 2 days to 14 days, but an average of about 5 days after infection. But that long incubation period out to 2 weeks is one thing that makes COVID management quite difficult. And it's something that we just don't see with flu, the cold, or many of our other respiratory viruses. Both flu and COVID spread via respiratory droplets. And with both viruses, it is possible to spread the virus for at least maybe 1 day or so before symptoms begin. In terms of flu, with older children, older school-age children and adults, your peak contagious period is that initial 3 to 4 days after exposure and symptoms begin. However, in infants, and those with weakened immune systems, whether children or adults, that infectious period is longer. COVID, like I said before, you have the potential to be contagious for longer, whether that's 2 days before symptoms begin or out to at least 10 days from symptoms appear. And I put 10 days plus because that really depends on your underlying immune system. And so we know that in patients who are immune compromised or otherwise immune suppressed, that period of time of shedding can be outwards of 20 days or longer in certain circumstances. So quite variable from the COVID perspective. So flu and COVID both transmitted via respiratory droplets, person to person, as I mentioned, requiring close contact, and then either through coughing, sneezing, talking, human contact, and then fomites, or those commonly touched surfaces. And in general, COVID is more contagious or more easily transmitted than the flu. And this has been something that's been talked about quite a bit during the past 2 years with COVID. But just a little bit about this R naught value, or just a measure of how contagious is this virus, or how many people each sick person will infect on average. And so this is looking at your centralized infected person here, and how many people, denoted by the additional red people around this central person, would be infected based off of one sick individual. And so here we have our friend, the flu. And on average, one sick kiddo would infect 1.5 other people. You can see MERS and Ebola here, two infectious diseases that thankfully are not here in this country. SARS, thinking about to the initial SARS outbreak of the earlier 2000s. And then here we have COVID-19. So with each sick person with COVID-19, and there's an asterisk here because this is changing, and I'll show you how this has changed with Delta in particular. Initially, it was about 2.5 people as compared to the influenza 1.5. The ones lower on this list, you can see that this R naught value is quite high. So things like mumps, rubella, smallpox, and certainly measles, being every infectious disease in hospital or healthcare epidemiologist's main concern that gives us nightmares. These have a much higher R naught value, but thankfully these are also infectious diseases for which we have vaccines, and why vaccines are so important. And we'll come back to vaccines for flu as why that's also very important. And then certainly now that we have COVID vaccines. But this is looking at how that R naught value has changed as we have had different strains and different variants of COVID. So here we have the original strain with the R naught value of about 3. The prior slide said 2.5. This R naught value changes over time. And so somewhere between 2.5 and 3 was the original strain, or the alpha variant. With Delta, and why it was such a big deal, was this R naught value increased to about 7 people. So for every one sick person, they had the potential to spread or infect 7 additional people. And that is why Delta was such a concern, and is still such a concern, and why things like masking and vaccination is so important. So just a little bit about transmissibility. Flu, not as transmissible, not as contagious as COVID, certainly not as contagious as COVID Delta variant, but still a concern when you're thinking about things like keeping kids in school, keeping people in the workforce, and trying to maintain some sense of normalcy throughout flu season. So high-risk populations are similar between the groups with regard to older adults, underlying medical conditions, and pregnant women, but it's been an evolving topic with regard to children. And that has to do with strains pre-Delta and then what we saw with the onset of Delta. So in pre-Delta, the risk of complications in healthy children was felt to be higher with flu, but certainly in those children with underlying medical conditions, there was a risk with both flu and COVID for complications. What we have seen with Delta is more of a signal with children, even healthier children, than we had seen with prior variants. And you know, definitely this is something that's going to be monitored throughout the rest of this season. And then this entity down here in school-age children, which is unique to COVID, called the multi-system inflammatory syndrome, or MIS-C, which is a rare but devastatingly, overwhelmingly inflammatory condition, particularly with children who end up in the hospital. And that is specific to COVID, not flu. So there are a lot of different great resources, and I'll point you all to some additional ones at the end, looking at sort of how to tell the difference between flu or COVID. And one is from the American Academy of Pediatrics. And so if you just Google, there are different graphics and different comparison tables that I think are helpful to look at. So how do you test for flu in children? There are a variety of different tests. Most of them will sound similar because they're ones that we talk about with COVID all the time. And so that being these rapid diagnostic tests, particularly either with RNA detection or antigen detection, and then the nucleic acid amplification tests, or these reverse transcriptase PCRs, which detects RNA. These rapid tests are very widely available, and you will see them often in children who go to their pediatrician's offices to get tested for COVID and flu. Their advantages are that they're rather fast, but you can see here in terms of sensitivity, it's quite variable. So RNA detection by far and away across the board is the most sensitive, meaning you can trust a negative test, and it will oftentimes detect B flu if it is there. Whereas with antigen detection, sensitivity is much lower. And so you may miss cases as well. Other ways to detect flu with culture, like you might with other bacterial infections, is really rather limited and not relevant to basically any pediatrics office. That would be more in the research setting. What will be helpful this year are combination tests. And so this is an antigen test for both COVID and the flu, to where you would have potentially one sample from a kiddo that you can test for both at the same time. And I think that'll be really instrumental in providing, certainly guidance to parents about what it is that's causing their child to be sick this fall and winter. Thinking about flu season being mostly October through probably May or so, but this year might be a little bit different than in seasons past. It'll be very helpful in terms of therapeutics, in terms of when children can go back to school, other contacts, that type of thing, to know in one foul swoop or swab whether or not these kids have COVID or flu. And then there are also PCR testing kits now that will test for both as well. And these are both of these have been things that we've been using in the hospital for the past almost year at this point. But from an outpatient perspective, will be helpful this fall for children. And then looking at treatment. And so this is from the American Academy of Pediatrics, looking at dosage and schedule of flu antiviral medications in children and the recommendations for this flu season, with oseltamivir or Tamiflu being our most commonly used treatment, as well as chemoprophylaxis, or trying to prevent infection if someone has had a really close contact for flu. And so with kids, those are the different recommended dosages. You can tell that it's based off of weight and based off of age. This is something that oftentimes will be started within the first 48 hours of infection, but can be started later in certain circumstances, depending on what the pediatricians recommend. And then there's some other medications that might be used in different circumstances, but less commonly, is the zanamivir, peramivir, and baloxavir. Some more so in the hospital, but since they're not as commonly used, I wasn't going to talk about them much in detail. A lot about flu, what it is. We talked about how it's transmitted, but how do we prevent children from getting flu? And preventing those awful complications that I detailed on the beginning slides, as well as preventing, the most serious complication, which is flu deaths every year. And so influenza vaccines are integral to protecting our children and they're integral to keeping our children in school and healthy in school. And so the CDC recommends a flu vaccine essentially for everyone over 6 months of age or and older, with very few caveats or contraindications to truly receiving the flu vaccine. We know through our data that this is the best defense against getting the flu, also against the potentially serious consequences or adverse events of the flu that I detailed on earlier slides, as well as spreading flu to others. So thinking about spreading flu within the classroom. We know that through looking at our data from seasons past, not so much last year because it was so unusual with so few flu cases across the board, that flu vaccines prevent millions of illnesses every year, hundreds of thousands of doctors' visits, certainly prevents missed school days, risk of hospitalization and death in children. And so these are two papers that I pulled that talk about those two aspects. So preventing hospitalizations and preventing deaths in children. And these numbers are quite astounding, upwards of preventing over 60% of possible pediatric deaths simply by getting the flu vaccine alone. So it is very efficacious. It changes season by season depending on how closely related the flu vaccine is to the year circulating strain. But what we know through our data in the past is even if our vaccine does not perfectly match the circulating flu, there is enough cross-reactivity that it still provides some protection and still provides some protection against having children and adults ending up in the hospital and dying. So the flu vaccine is extremely important. Reiterating again that everyone over 6 months of age or older gets a seasonal flu vaccine. The timing is essentially now. So the ideal time period is by the end of October, but that does not mean that after October, you should not get your flu shot. You should. So if there's any delay, as long as there is circulating flu virus in the community or before there's circulating flu virus in the community, you can still get your flu shot. Some children do need more than one dose, and in fact, they would need 2 doses, and that includes children who have not, who are young and who have not received a flu vaccine in their past, or even older children who have never received a flu vaccine. And in order to become fully efficacious or fully protective, that's about 2 weeks after your vaccine in order to develop those antibodies against the different flu viral strains. And so with our flu vaccines, you hear the term quadrivalent thrown around, and that means that our flu vaccines are based off of 4 different influenza strains, 4 different strains that scientists each year, based off of all of their work, believe to be the main circulating strains in the community. There are 2 different types or ways that children can receive these vaccines. So one is through these injectable influenza vaccines, like what we are used to as adults, where you get an injection into your muscle of your deltoid, most likely, and really well tolerated. With that, you can have some localized reactions, some pain in the arm, maybe some redness, but otherwise really well tolerated. And then you have this other option of a live attenuated influenza vaccine. So whereas this one, the injection is for children greater than 6 months of age or older, this live attenuated vaccine does have more restrictions because it is a live variant of the flu. So children have to be over the age of 2. For adults, they cannot be over the age, I believe, of 65. And that's just to try and prevent any complications, as well as these children or adults need to not have certain underlying medical conditions. Adults, they can't be pregnant, those types of things. So each year, the injectable vaccines are what you see most commonly, but just knowing that there is an intranasal live attenuated influenza vaccine available out there for kids. In terms of which vaccine our children should get, really the best answer is they should get vaccinated, and then trying to decide between whether or not they receive the injectable or the intranasal is an excellent discussion between our children and the pediatricians. Other than vaccines, there are a handful of other everyday preventative actions to preventing the spread of flu in our school-age children. And these themes are very common since this is what we have been harping on with COVID for the last 2 years. And that includes very good hand hygiene, washing your hands well and often, using hand sanitizer, more so throughout the day than you might at other times in the year. Very important to stay home if feeling sick, and I'll talk about that guidance in just a moment, as well as excellent respiratory hygiene. So coughing into your sleeve or your elbow rather than your hands to prevent transmission from person to person that way. Covering your coughs and sneezes, if not with your elbow, then with a tissue, those types of things. And then masking. So what we saw last year was a big difference in our flu season, like I described. And masking had a big effect with that. We know that masks are efficacious at preventing the spread of COVID in our schools, and they certainly are going to be efficacious at preventing other respiratory viruses that are spread by respiratory droplets, and that includes the flu. So through all of these, as well as vaccination, all of these measures are protective for our children, protective to reduce spread within the school and within our school-age children population, as well as keeping kids in school. So with sick children guidance, children who have a fever or who have other symptoms of these infectious respiratory viruses should stay home. And they should stay home for at least 24 hours after they have had their last fever before returning to school. And that is 24 hours after their last fever without the addition of any fever reducing medications. And so once that criteria is met, then hopefully we can get our children back into school. And there are a lot of great resources out there thinking about flu as well as COVID, but a lot of this data comes from the CDC, as well as the American Academy of Pediatrics, where they have these wonderful toolkits and specifically flu campaign toolkits with a lot of great graphic representation that I think would be helpful for you, everyone who is working with school-age children to pull from. And then most updated guidance from the American Academy of Pediatrics that was published in their Sentinel Journal of Pediatrics for the prevention and control of flu for this school or this season 2021-2022. And in this, here's just one example of these beautiful infographics from the CDC. Flu, a guide for parents, talking about different things to look for in their children, different aspects about why the flu vaccine is so important, and then again, what you do if your child is sick, as well as when they can go back to school, or if they can go to daycare or camp, those types of things. So this again is from the American Academy of Pediatrics. So how do we avoid a twindemic, a term that they have coined to talk about what could happen this year with a flu epidemic, or just our usual seasonal flu epidemic that we see from that October to May time period every year, on top of COVID, with the potential for another COVID surge around the time of the holidays. And so with flu in particular, again, emphasizing the importance of flu shots. This will be so important this year. It's important every year, but so important this year more than ever for our children and adults to get vaccinated against the flu, and having those conversations with their pediatricians to make sure that not only are they up to date on their flu shot, but also on other shots. And again, emphasizing that this is how we keep our families and communities healthy every flu season. I will end just a little bit about wearing your mask. And so, last year was a remarkable year for a lot of different reasons, tragic in one, but one of the upsides of wearing your mask was that we really had a fantastic flu season, almost a non-existent flu season. So we know that masks do work for the flu. And so this is our UAB blazer wearing its mask.